everyone, Professor Hanson here to talk about the autonomic nervous system, specifically the sympathetic nervous system, and adrenergic agonists along with antagonists. So we talked about it in class, and this purpose is to reinforce some of that learning and allow you to be able to kind of put it all together. So make sure when you're reading this or when you're listening to this, you have your sympathetic nervous system man next to you so you can reference it as you go. So the part of the autonomic nervous system we're going to talk about is just the sympathetic nervous system. After the first exam, we'll go over the parasympathetic nervous system and the medications and neurotransmitters that go along with that. So adrenergic agonists and antagonists. The adrenergic part literally means using epinephrine or norepinephrine. An easy way to remember adrenergic is to think add. So if you're going to use an adrenergic agonist, you're going to act on whatever that normal receptor does. So remember, an agonist acts and an antagonist blocks. If it's adrenergic, it's working within the sympathetic nervous system. If it's cholinergic, as you'll learn after exam 1, it's actually working in the parasympathetic nervous system. So we'll talk about that after the exam, separate these two so that they get a really good grasp on the sympathetic nervous system before we talk about the other way it goes. Okay guys, so the autonomic nervous system is amazing, right? It works even without your knowledge. It is automatic. That's what it means by autonomic. And these changes that the sympathetic nervous system makes alongside the parasympathetic nervous system work in opposition of each other and make tiny rapid controls in order to bring that body back to homeostasis. So everything it's doing on one side and the other are combating each other to bring the body to that normal place, that homeostasis. The control center, what's in the hypothalamus, the medulla, and the spinal cord, is where all of these impulses are going to and from. So in the peripheral part of your body, these afferent nerve fibers are going to take those impulses all the way back up to the control center. They're feeling, they're hearing, and then they're going to send efferent impulses back in order to tweak, make tiny changes in order to bring that body back to homeostasis, depending on whatever that response is, right? So it feels something, it hears something from the body, and it makes tiny changes to bring that body back to normal. Okay guys, we're really not going to go into depth on this slide at all. This is just for your review. It's a total review of patho, things that you talked about in pathophysiology for nursing, and then also before that in anatomy and physiology. So this is just, again, a real quick snapshot of exactly how those impulses are traveled to and from the command center. So moving ahead here, we're going to talk about the differences in the autonomic nervous system and exactly where it falls into our discussion here. So the peripheral nervous system, it's divided further into the somatic and the autonomic. We're not really going to talk about the somatic nervous system right now. It's not really part of this discussion for the sympathetic nervous system. But we are going to talk about the autonomic nervous system and its divisions. So the autonomic nervous system is divided into systems that work in opposition of each other, just like we discussed a little bit ago, the sympathetic and the parasympathetic nervous systems. And so I know this is mostly patho review in this portion, so we're really not going to dive deep into that. So I did skip a slide. I moved ahead because, again, this is really just very a brief overview, so you kind of know where we're talking about on that chart. So if you get out that in a nutshell chart and at the top there, you're going to see where we talk about the CNS, the nervous system, the the peripheral nervous system, and then how it's further broken up. So right now we're branching off that autonomic nervous system and we're over on the sympathetic nervous system. So that's what we're talking about right now. Okay guys, let's fast forward to the part that really matters when it comes to the sympathetic nervous system. There's a mnemonic down here at the bottom for you to discuss just the neurotransmitters themselves. The ones that we're going to be talking about in the sympathetic nervous system are going to be dopamine, norepinephrine, and epinephrine. Now, the acetylcholine you see here on this slide, that's going to be discussed in the parasympathetic nervous system. So after exam 1, that's when we'll get into that. But for now, focus on dopamine, norepinephrine, and epinephrine. Now, I'm going to reference exactly the cell and structural aspect of how these neurotransmitters are stored, but you'll see in your book, you're going to see a lot of pre-ganglionic and post-ganglionic references. I'll talk about them briefly, but it's really not something I'm going to hold you to as far as knowledge going forward in the class. Just so you can understand, we'll talk about it just a little bit. So if you recall from patho, and the neurons are the structural unit of the nervous system, and those structural units are the ones that conduct those impulses. Each neuron has a cell body, an axon, and a dendrite. The axons end in ganglia, so that's again where you see that reference for pre and post ganglionic receptors. Those ganglia are the ones that receive the information from the central nervous system, and then they relay that information to the effector cells. Now, the effector cells are the ones where it's going to create a response on that effector cell. Depending on where it is what happens. What response are you going to get? Once it wants to create a response, that axon is going to release that neurotransmitter. That neurotransmitter is in of itself a chemical. That chemical is going to create an effect. So once you know where it's going and you know what that cell is designed to do, you will understand what the neurotransmitter is going to cause, what kind of a reaction, what is it going to do. This is a visual depiction. You can kind of see exactly how much the sympathetic and parasympathetic nervous systems affect the body, and it's pretty creative. There's a lot that they do without you even knowing that they're doing it to put that body back in homeostasis. So, your sympathetic nervous system, that's that system that's going to give you that fight or flight response. Anytime you're in a stressful environment, you're sitting down for your first farm test and you're super anxious and you're nervous and your body starts to respond to that and you don't even tell it to do it. So you're getting anxious, your heart starts to race, you might even breathe a little bit fast. You're going to start feeling like maybe it's difficult to see up close because your vision's blurring. You might even sweat. And then your legs might tingle, although you don't know why. And you're breathing a little bit heavy. So these are all responses that start happening, and you don't even know that it's happening. Your body is trying to bring it back to homeostasis, working together behind the scenes. When you have an adrenergic response, those nerves are being stimulated by norepinephrine. So that catecholamine, and that's what norepinephrine is, it's a chemical called catecholamines. The catecholamines include other chemicals, dopamine, serotonin, and epinephrine. Serotonin is a catecholamine you're going to learn more about, but you won't learn more about it in pharm. You're going to learn about that when you get to psych. There are lots of chemicals and medications that do affect serotonin. Really important to understand. So when you get to that point, make sure you don't dismiss this and you learn what serotonin does. For now, what we're going to focus on is norepinephrine. So once we eat foods containing tyrosine, so those are going to be chicken, turkey, milk, cheese, yogurt, cottage cheese, so there's a lot of dairy there, peanuts, almonds, avocados, bananas, lima beans, pumpkin seeds, and sesame seeds. So that's a lot of stuff, right? Those foods will contain tyrosine. Once we put those foods into our body is going to convert them to an enzyme called DOPA. Another enzyme will help DOPA be converted into dopamine. Remember, that's the naturally occurring version of dopamine. All of those adrenergic cells can convert that dopamine to norepinephrine, and then it gets stored. So once our body stimulates that sympathetic nervous system, the nerve that's going to be holding it, when it gets stimulated, it's going to release it, and it's going to travel to wherever it's supposed to travel to create its effect. And those effects we'll discuss just a little bit. But once the body's done with it, it's going to get recycled. Whatever isn't used, it gets reuptaked. So it gets taken back up into the nerve. There's another way that it can be reused or recycled, and that's with enzymes called monoamine oxidase and then catechol-O-methyltransferase, or MAO and COMT. These are enzymes that the body uses in order to help get rid of that norepinephrine that doesn't need to be used anymore. If you recall from lecture, if we allow the norepinephrine to just continue producing an effect inside the body and it goes unchecked, can you imagine all of those effects? Take a look at your sympathetic nervous system, man. If we allow alpha 1 to just continue to be stimulated without being unchecked, then you have enormous vasoconstriction. There'll be nothing there to kind of balance that. You'll just have a ton of constriction in those vessels, and along with all of the other things that go with just a sympathetic nervous system response that doesn't get stopped. So, moving on, there are specific receptor sites that the norepinephrine and epinephrine are going to work on, and those are going to be your alphas and your betas. If you recall, dopamine can only affect dopamine, although dopamine can affect other receptor sites. Only dopamine can affect dopamine receptor sites. So here you'll see listed just alpha 1 and 2 and beta 1 and beta 2, and that's because those alphas and betas can't actually, not everything affects them. They're specific. You can see from that chart I showed you that epinephrine is going to activate alpha 1, alpha 2, beta 1, and beta 2 with extra affinity for beta 2. Norepinephrine is going to activate alpha 1, alpha 1, alpha 2, beta 1, but not beta 2. And then dopamine is going to be activating dopamine, because it's the only one that can activate dopamine, along with alpha 1 and beta 1. Your alpha 1 receptors, so where are they located? Well, if you know where they're located, you'll have a pretty good idea of what they might be able to do. Now, I don't need you to recall or to memorize where they're located. If that works for you to know where they're located, it will help you eventually to know exactly what kind of effect it will create on that particular organ or that muscle or cell. So it's going to be located on the eyes, the blood vessels, the bladder, the male sex organs, and the prostatic capsule, so the prostate. Your alpha 2s, remember, if you recall from lecture, they're really not all that significant in pharmacology, and there's a couple reasons for that. They do create, if you stimulate, an overall CNS effect. Now, that's pretty bad because we're not identifying specific things in the CNS. We can't trigger just one little thing. We affect everything when we trigger that CNS. So beta receptors, so there's beta 1 and beta 2. So the beta receptors are going to be on the heart, the kidney in beta 1. In beta 2, you're going to have the smooth muscle of the lungs, the coronary arterioles, the uterus, the liver, and the skeletal muscles. Dopamine receptors. Now remember, dopamine can only do dopamine receptors. Dopamine can do other ones, but only dopamine can trigger a dopamine receptor. And you can find those in the kidneys. Now that's an easy one to remember because a lot of what dopamine does, it affects the kidneys. So I get this question from students all the time. How can I get this? Now, so we're going to talk about those neurotransmitters. The only ones we're going to talk about here are going to be norepinephrine, epinephrine, and dopamine. Again, you might want to grab your SNS man. It will help you to be able to put this all together, kind of see the big picture. Epinephrine is a catecholamine. If you'll recall, catecholamine is a chemical that produces these effects in the sympathetic nervous system. So it's one of the mediators of fight or flight. It's going to cause that fight or flight response. It is released in the sympathetic nervous system. It is produced and stored primarily in the adrenal glands. Now, norepinephrine is different. That's going to be next. But the epinephrine is primarily stored in the adrenal glands. And that's an interesting thing because it is both a neurotransmitter and a hormone. So as you're going through your reading, you might see them talk about how epinephrine is a hormone. It is also a neurotransmitter. Either way, whether it be neurotransmitter or hormone, it doesn't matter. It's going to produce the same result. So here you are with your epi. It can activate everything except for dopamine, alpha 1, alpha 2, beta 1, beta 2, and not dopamine. And then it is going to be the one mostly responsible for triggering that heart rate and the cardiac output. And it can also boost that physical and heightened awareness. Kind of an interesting thing. You don't really even know it's happening except for that you are going to be triggering that fight or flight response. Well, if you think about all the things that happen when you have fight or flight, you'll understand why it would promote or boost that feeling of heightened awareness. Norepinephrine, again, another catecholamine. Remember, it's a chemical that is released inside the sympathetic nervous system, another mediator of the fight or flight response in the sympathetic nervous system. However, this one is going to be stored and released in neurons of the sympathetic nervous system. You remember where it's stored? In that ganglia over there, right? And there's some in the adrenal tissue, not all that much. We're going to activate alpha 1, alpha 2, and beta 1, but not beta 2. And if you take a look at your sympathetic nervous system, man, you're going to see that it can increase all kinds of stuff, right? Works through when it's activating your or increasing your blood pressure. Understand it increases your blood pressure because it also works through vasoconstriction. Even though you don't see that on there, that's a big part of what it does. When you want to stop that response, your COMT or your MAO enzymes are going to be the one that get rid of it. They reuptake it into the nerve endings, or they get rid of it, or it goes through that liver. Dopamine. Another catecholamine. It is in the sympathetic nervous system, although this one is produced by the midbrain and the hypothalamus. So different from epinephrine and norepinephrine. And it's going to be the one that stimulates those dopamine receptors. Remember, where is dopamine? It's on the kidneys. And so it can trigger all of those dopamine receptors. Now, yes, there is dopamine receptors 1 through 5. We aren't going to get that specific. You just need to know that the dopamine receptors are going to be on those kidneys. Now, there's a couple of things that are going on with dopamine. It does have a effect in locomotion, and it also has been found to be a part of the intellectual emotion, pleasure, and reward response. That is because, and you'll learn later, that dopamine is one of those things that we try to promote longevity with patients who have Alzheimer's. They just don't have that happy response anymore. They kind of have a flat affect. They don't have a whole lot of pleasure. They don't respond to pleasure in the same way that other patients do or other people do. Also, with behavioral health patients who just have a difficult time with depression, they find that maybe they just don't have the same amount of dopamine in their body or they don't reuptake it the same way. So we want them to have it for longer. So we will end up interfering with their reuptake. We allow dopamine to hang around much longer. So we do know also with that locomotion that low dopamine levels are going to cause some uncontrolled and jerky movements, just like you see in Alzheimer's patients. Or in high dopamine level, again, those jerky repetitive motions, looking more like tics, not so much with the uncontrolled motion in low dopamine levels. They're going to be more jerky. Okay, so let's get more deep into these adrenergic agonists. Why, you might be asking, they're kind of separated on this lecture, and that is because although they are naturally occurring in the body as chemicals, those neurotransmitters, they can also be given um, a little bit like a drug, right? We're producing an effect, we're creating a response, we're stimulating more of the same. So even though they're naturally occurring, or several of these are, they can also be given to a patient to produce a response. And so either way, they're an adrenergic agonist. Okay, so these adrenergic agonists, remember, if it's adrenergic, that means it's in the sympathetic nervous system. It is creating a response in the sympathetic nervous system as an agonist. So an agonist is going to act, it's going to produce the same response that receptor was already designed to do. That is what's called a sympathomimetic. So in the sympathetic nervous system, it is mimicking the natural action of that receptor. So it is sympathomimetic. It is creating the same physiologic response as whichever receptor it is designed to interact with. So remember, an agonist acts. The agonist is going to produce the same response. These agonists can act on different receptors, all of them or just a couple. You will see when we talk further about those as we get deeper into this. And they can act in a couple different ways. So, how they act is what we call mechanism of action. So, the MOA. So, the mechanism of action. In just a few minutes, we're going to talk about all the different ways those can, but they can be either direct or indirect. So, if it's a direct acting mechanism of action, that means it's typically going to occupy the receptor site itself. If it's indirect, it's going to do something to modify the release of that neurotransmitter, or it can do both. So there's 5 different ways that these neurotransmitters, also adrenergic agonists, same thing, can create a mechanism of action. So let's get into those. These can be either direct or indirect. If you kind of read them, you can kind of see which way it is. It's direct or indirect. It can be both. So, one, these neurotransmitters and agonists can block the reuptake of neurotransmitters. Okay, remember, what interferes or what helps with that reuptake? That's going to be those enzymes, MAO and COMT. So, if it's blocking those, preventing the reuptake of those neurotransmitters, it is promoting more stimulation inside the sympathetic nervous system. Two, it can block the receptor's site, which means that the neurotransmitter can't stimulate that receptor. It's just sort of floating around, not producing an action. Three, it can block the enzymes that break down those neurotransmitters. So, again, those MAO or COMTs. And then it can't even produce that enzyme. So if there is no enzyme around, it can't break down or reuptake those neurotransmitters. This is different than number one. In number one, those enzymes are still present, but it prevents them from reuptaking those neurotransmitters. In number three, the enzymes aren't even produced. So there isn't any around, and this promotes, again, more stimulation of the neurotransmitter, and it's in those concentrations, right? So there's a lot of concentration of neurotransmitter in the synapse. Number four, it can stimulate the receptor sites itself. So if there is no neurotransmitter, there's no adrenergic agonist, these receptor sites can be stimulated in any case. So and lastly, number five here, we can cause the nerve to release greater amounts of the neurotransmitter. So it's going to produce and release more, allowing it to find that receptor and trigger it, creating more of a response. So these are 5 different ways these mechanisms of actions could work for neurotransmitters and adrenergic agonists. Okay, so here's another list of these alpha and beta adrenergic agonists. That means that each of these medications are going to affect alphas and betas in some combination. Dopamine, that is the synthetic version of dopamine. And there's dopamine, which is also a neurotransmitter, but can be given as an adrenergic agonist, as like a medication. Ephedrine, that should sound familiar. Ephedrine is actually a naturally occurring herb, and that main ingredient in that ephedrine can be synthesized as a medication. That one would be pseudoephedrine. You have seen pseudoephedrine. That's now they put those in cold remedies, and that's regulated in over-the-counter medications. But in high doses, it does produce a dramatic vasopressive effect. And then there's epinephrine and norepinephrine. Now, the next few slides, we're going to talk about the pharmacokinetics of these adrenergic agonists, also neurotransmitters. Remember, they're kind of interchangeable. And they're going to be grouped together, these slides are. So it's not going to be individual pharmacokinetics for each individual neurotransmitters. This is grouped together in these slides. So it's pretty generic. So the next ones we're going to talk about here, again, these are all the same medications: epinephrine, norepinephrine, dopamine, dobutamine, and ephedrine. You're going to see some generic names on there, and you're also going to see some trade names. Norepinephrine is very commonly referred to as Levophed in most clinical situations. And epinephrine, although you can see adrenaline there is its trade name, it is mostly referenced as epinephrine in most clinical situations. Kind of confusing. It is rapidly absorbed via IV, and it's metabolized by the liver and excreted in the urine. Okay, so let's take a few minutes and talk about the pharmacokinetics of these neurotransmitters and adrenergic agonists. So, the heart failure, shock, sepsis, hypotension, cardiac arrest, and anaphylaxis. So, a lot of those are similar except for anaphylaxis. You're going to see a lot of situations or a lot of medical diagnoses here where it's going to affect both the heart rate, the heart contraction, and the blood pressure in most of those circumstances. Again, anaphylaxis also with the bronchospasm. But you're going to see that there's a lot of problems with the heart, right? So the blood pressure's not right, heart rate's not right, heart's not beating the right contraction force. And so we can give these adrenergic agonists, again, also called sympathomimetics, also called catecholamines. I know it's a lot, but I want to keep saying it so you guys remember that there's a lot of different ways we can reference what these particular adrenergic agonists are also called. So there's different ways in which they create an effect, the actions with which they can be used. So I'm going to introduce you to a couple words here. So the heart rate. Anything that increases the heart rate is referred to as a chronotrope. It's easy to remember when you realize that the word chronotrope actually has HR in it. That's how I always remembered chronotrope helps the heart rate. So if it's going to affect the heart rate, it's referred to as a chronotrope. That means it's positive. It's creating a positive effect, making that heart rate higher. So these medications, epinephrine, norepinephrine, dopamine, dobutamine, neosynephrine, these are all medications that are going to increase the heart rate. So it's a positive chronotrope. However, when we're increasing that heart rate, we're going to create an effect when it comes to the way the heart contracts or the force of its contraction. That is called an inotrope. So as a medication increases the force of contraction, it is a positive inotrope. Do they both do this? Well, there's all kinds of effects that we're not going to get into that will create this dual effect where an increase in the heart rate will also stimulate that cardiac contractility. We're not going to get further into that. You'll get to that more when you get to critical care. Just know that these medications do affect a lot, even though in your sympathetic nervous system, man, we kind of have them a little bit separated. So you're going to see on there your epi, your norepi, and your dopamine are listed in both your beta ones and also your alpha ones because they do create both a chronotropic and inotropic effect. Now, there's other things that these medications do, right? They can constrict those vessels, creating an increase in blood pressure. They can dilate those bronchi, helping you to breathe deeper and promote more oxygen circulating through your body. It's going to help reduce that intraocular pressure. It's going to dilate those eyes, and it's going to help with glycogenolysis. So it's going to help glucose breakdown. It's going to become available for use, giving you more energy. Remember, for that fight or flight, right? It also promotes sweating. So now that you know what their uses are, you also have to consider who can't get these. Well, they're contraindicated to anybody who has a hypersensitivity. Now that sounds odd, right? We're not saying allergy here because if you think about it, these are all mostly occurring naturally in the body. They are normal catecholamines that exist in the body except for dobutamine. So, can a patient be sensitive to them? Yes, absolutely. So, even though they're naturally existing, if we give it to the patient, we may create a response that is overwhelming or maybe undesirable, something much more than we were expecting. Some patients are very sensitive and some patients are not. So, no two person is alike, remember. So, if I give one person 5 milligrams of one medication, they may respond overwhelmingly. If I gave 5 milligrams to another patient, they may not respond at all. So these are all individualized. That's why nursing is so important. You need to be able to know what to expect the medication is going to do and be able to respond to the results of that. Now, a couple other things, right? Do we give them to pregnant patients? Yes. Well, again, it's naturally existing in the patient's body as catecholamines, but do we want to give them more of that? Well, we have to know that it's going to affect the fetus as well. So, do we really want to? We have to weigh those odds, right? Do the pros outweigh the cons? Adverse effects. So these coupled in here are also some side effects, right? So side effects would be something we expect to happen, and we have to decide, do we want to mitigate those effects and allow the patient to stay on the medication? Adverse effects would be like it's undesirable. If the patient does not tolerate it, we cannot use this any longer. Though at that point, the cons outweigh the benefits. So arrhythmias, right? Arrhythmias, anything that we're stimulating on that beta 1 in particular is going to cause increased arrhythmias. Vasoconstriction in the extremities. So this is something that's really important. So what we're doing is we're squeezing those vessels in the peripheral extremities and other parts of your periphery, right? So we're squeezing those and we're shunting that blood back to the core. By doing that, we're preventing normal perfusion to those tissues and those vessels. The problem with that is that it might get to the point where if the patient's on this for any length of time, we may find that the patient's skin starts to necrose. So it's not uncommon for patients who are on these vasopressors for any length of time to start having purple and black hands and toes, and leading those to amputations or cell death. So really important to monitor our patients' extremities when they're on any of these medications. Hypertension, of course, this is expected, right? What we're trying to do is raise the patient's blood pressure, but if you're not diligent about how you're giving the medication to the patient, you may cause a situation where there's too much of that medication leading to hypertension. Palpitations go right along with arrhythmias. If your patient's complaining of palpitations, you need to pay attention. That would mean it could be leading to arrhythmias. Tachycardia, again, these medications affect the heart rate. We expect the heart rate to rise. We have to decide at that point, has it risen too much? Has it risen to the point where we now have a risk versus benefit situation? Chest pain, difficulty breathing, nausea, vomiting, right? Those are all side effects. Constipation. Well, if you take a look at your sympathetic nervous system, man, when we antagonize or when we give an agonist to beta 2, or when we stimulate beta 2, we're causing a decrease in bowel motility and bowel secretions. So, of course, it's going to cause constipation. There's no peristalsis anymore. Headache, sweating, anxiety, piloerection. These are all side effects. Now, drug-drug interactions with this is going to end up making more sense as you go along. Now, if you'll recall on one of our slides earlier where we have the tyrosine and how tyrosine is used in the body to convert down to dopamine, and then dopamine makes it into norepinephrine. So if you look down that chart, well, how do we get rid of it? How do we stop the action? Well, we stop the stimulation by using that COMT and MAO. Well, what do you think happens if we give a monoamine oxidase inhibitor? If we give that, what we're allowing to happen is that prolonged and increased effect of the sympathetic nervous system. We are allowing more of it. We're not stopping it. So we do this along with the tricyclic antidepressants. We do this for patients who suffer from depression, who suffer from behavioral health issues. And if we give them these TCAs or these MAOIs, what's happening is we're providing a prolonged effect. Well, if we give these alongside something that's going to stimulate that sympathetic nervous system, we are going to cause way more stimulation, right? Could lead to adverse effects. Now, an adrenergic antagonist, why wouldn't we give this? Well, we wouldn't give it with an adrenergic agonist because they work in opposition of each other. It'd be like breaking even, right? We'd be giving one and then giving another, and then they would both break even. No point. Herbal Interactions, these are really important. There's a really high portion of our population that loves caffeine, right? They also love to reach for a Red Bull or a Rock Star anytime they feel tired because it's just okay. It's now become mainstream. Well, these Red Bulls and Rock Stars and the other energy drinks, along with pre workouts, contain mawang and guarana. Those increase the potential for a patient to suffer from severe hypertension leading to stroke and death. Kind of a big deal. So, as the bedside nurse taking care of these patients, you can also probably gather by now you'd be the nurse in some high acuity unit, probably more like the ICU or the emergency department. However, you can see that even if you're the nurse on a lower acuity unit, if you spot one of these patients that's getting very sick and heading towards a situation where maybe their blood pressure is falling or their heart is failing, you might have to act before the patient can leave your unit to go to a higher acuity unit. So you should still be able to recognize and know what the medications do. The first thing you're going to do if you have a patient who hasn't been put on this medication yet is do a physical, a thorough assessment. Make sure you know exactly what your patient looks like right now before we do anything about their situation. If your patient is already on these medications, and you're going to want to make sure you do a very thorough assessment of your patient as well. It doesn't prevent you from doing that. You need to just do it more thoroughly and more frequently. Know how your patient looked when you get there. Tell me about their history. Is the patient able to speak? If the Then gather the history from the patient. If the patient can't speak, then make sure you reference the family. What do they know about the patient? Does the patient take herbal medications? Does the patient take other medications? Do you know everything about this patient? Assess your vital signs frequently. What's titrating mean? Well, what titrating means is going up or down on a medication as needed. If your patient's blood pressure falls outside of what the goal range is listed by the physician, then you would titrate the medication dose to get it back into that range. If your blood pressure goes too high, you would titrate your medication down. If your blood pressure falls too low outside the range, then you would titrate your medication up. So you're doing whatever you can every few minutes in order to make sure that you get that patient's blood pressure into the goal range. This is also for heart rate as well. Now, when it comes to EKG changes, if you'll remember when we stimulate beta 1, we can be increasing the chance that our patient would have arrhythmias. What does that mean to you? Not knowing a whole lot about a normal EKG yet is a little tough to understand what ectopy and arrhythmias are. Just remember that the more ectopy a patient has, that means unusual beats. The more potential there is for the patient to enter into a heart rhythm that is not normal, creating a situation where they might not have a good perfusing heart rhythm. That leads the patient higher risk for heart attack. You're going to want to make sure you listen to the patient's breath sounds regularly, especially if we're doing something that's going to promote bronchodilation, right? Or if the patient is on a medication that is going to prevent the dilation of those bronchi, as you will find out later in antagonists, you absolutely want to listen to those lung sounds. Know what they sounded like before, know what they sound like frequently. Urine output. Well, if we're giving our patient dopamine, right? Remember, dopamine receptors are found on the kidneys. We're going to be promoting that urine output. We want to perfuse those kidneys. How are our kidneys working? Monitor the urine output. Is it doing what it's designed to do? If your urine is falling below what it should be, then you might need to increase that perfusion or titrate up on a medication to promote more urine output. If your urine output falls below a normal, you're going to want to let your physician know because there's a problem with the patient's kidneys that could be developing, like an acute kidney injury or acute renal failure. You're going to want to make sure you monitor the patient's labs because this is something that the physicians expect the nurses are capable of doing. If you see something that falls outside the normal, like a patient's electrolytes, or maybe you see that the patient's kidney function is getting worse, you're going to alert the doctor that you have found this and that you need to make some changes to the patient's medications. Now, you saw in those slides that the patient can have situations where we have infiltration or extravasation. If any of these medications infiltrate or extravasate, we can cause tissue death and necrosis. So it's really important to make sure your IVs work well. So let's talk a little bit about alpha and beta specific adrenergic agonists. Well, what we mean by this is that they're specific to either one or two or more of these receptors. That means maybe just alpha 1, maybe just alpha 2, or maybe alpha 1 and alpha 2, maybe just beta 1, or maybe just beta 2. So we want to take a look at these medications as well. So I have some listed here for you, some alpha specifics. That's going to be clonidine. That's just alpha 2. Midodrine and phenylephrine. Those are going to be your alphas. And then you've got your beta specifics. Now, this is not a complete list, and that's because there's a lot of medications on this list that just don't matter right now. Albuterol, you guys remember albuterol from our discussion? Albuterol is going to be a beta 2 agonist. And then we've got terbutaline. Well, that does a couple things in that beta 2. And then we've got isoproterenol and terbutaline. So the isoproterenol, we're really not going to talk about it much. It is listed in this PowerPoint. You can see it. I'm not going to do a whole lot talking about it. It's so toxic to the cardiac muscles and cardiac arteries that we really don't use it anymore. So it's kind of being phased out. Okay, so here we have a list of clonidine. That's also referred to as catapress. Midodrine, there's no other name for midodrine. And then phenylephrine, also called neosynephrine. These are going to be some alpha-specific adrenergic agonists. How are they absorbed? Pretty well. They have a rapid onset. That also means they typically have a short life except for clonidine. Clonidine is often given to patients outpatient in an outpatient setting through a patch, and it can have a prolonged effect. It's metabolized in the liver and they're excreted in the urine. The pharmacokinetics of phenylephrine, also called neosynephrine, that's what we're going to talk about right now. So what are they used for? Well, we can first give them a few different ways, and how we give it is going to determine what it's being used for. If it's given oral, that's going to be an extremely low dose, and that's going to be an over-the-counter use for allergies, upper respiratory infections, and then it's also given under physician's watchful eye for paroxysmal SVT, so that's supraventricular tachycardia. Not going to talk about that here. It's going to be given intranasal like Afrin spray, so as allergic rhinitis. Ophthalmology, that's going to be used by, again, an ophthalmologist. It's pupil dilation for glaucoma. And then if we're giving an IV, that's what we're talking about now. We're giving it for these really, really scary reasons of shock and sepsis and cardiac arrest. We only barely touch on it here, and you're going to be hearing a lot more about it as you go through adult health and critical care. So actions, what does it do? Phenylephrine is a very potent vasoconstrictor, and then it doesn't provide any cardiac or pulmonary effects. So just constrict. So think about it, guys. All we're doing is squeezing. That's it. It's not really causing any cardiac effect or any pulmonary effects. Midodrine. So a couple really important things to know about midodrine. We love to give it for our cardiac patients who have had cardiac shock or heart failure, or maybe they just had an MI. If we're going to give it orally, we give it to patients on an outpatient basis for orthostatic hypotension. So we're helping to raise their blood pressure just a smidge. Interesting, right? If it's being given IV, again, it's going to be done because we have a really sick patient who's got a lot of heart problems. How does it work? Well, it's only going to affect those alpha 1s, just alpha 1. That means, guys, what we're doing here is we're causing a situation where we're increasing the cardiac demand. Just alpha 1, just the cardiac demand. But interestingly enough, guys, we're not actually creating a situation where we're providing more oxygen supply. That's kind of interesting, right? So if we're doing alpha 1, that means we're constricting those vessels, increasing the peripheral vascular response. However, we're not triggering beta. So by doing that, we're squeezing, but we're not actually increasing the supply. That's a problem, right? We've got decreased supply with increased demand. This is going to create a situation where you have a really high risk for our patients who have just had a heart attack or a stroke, or maybe they have existing cardiac impairment. If we're going to give this to a patient who has existing cardiac impairment, we are putting them at even higher risk for heart attack and stroke. So if we're going to be giving our patients midodrine, it is not unusual that this is going to be coupled with something that's going to promote that beta. as a sympathomimetic, not just by itself. Now, also really important to understand about midodrine is that one of the most and the biggest problems with this is that you're going to potentially create a situation where your patient is going to have profound supine hypertension. What does this mean for you as the bedside nurse? Well, you got to lay your patient down and take their blood pressure, right? Something that you need to know. Also, you need to tell this to your patient. So they're going to want to make position changes very slowly, right? As they go from a lying down or a sitting or a standing position, they can cause profound supine hypertension. Definitely make sure that you're informing your patient of this. Okay, so let's talk about the very confusing drug clonidine. Why is it confusing? Because you're going to see on these slides some contradictory information. Well, why is that? Well, it's because clonidine is both partially an alpha adrenergic agonist and is also partially an alpha adrenergic antagonist, which means portions of it are going to stimulate and then portions of it are going to block different parts of the central nervous system. That can be very frustrating to understand. So I'm going to limit it to what I think is important for you to understand what we're using it for, because we want to give you the most clinical aspect of clonidine. It is used widely, it is used frequently, and it is used mostly for patients who have some psychological or behavioral or ADHD issues. These patients are going to be using it because it's going to help with awareness, even though it has a sedation. Sorry, I can't speak right now. Even though it's a little bit sedating, it's still going to bring them a little bit more awareness. It's going to help them focus their attention. Now, at the same time, it also is going to cause hypotension. It's going to promote further more hypotension. Now, here's what we want to make sure you understand about this. The most important aspect of clonidine is that the patient needs to taper down the dose. They cannot just stop it. If they stop the dose suddenly, they can cause severe rebound hypertension. So anytime you have a patient on clonidine, they have to know that the dose cannot just be abruptly stopped. They must do it nice and slow. So of course, if a patient has taken clonidine in the past and has had a problem with it, obviously we don't want to give it to them again, right? Sometimes this drug, because of its also antagonistic effects, can cause hypertension rather than cause hypotension. And then we really don't want to give it for any narrow angle glaucoma. It can actually cause worsening pressure in the eyes. It cannot be stopped suddenly. Just like I said before, you must taper down the dose. You can't stop it suddenly because it can cause sudden and profound rebound hypertension. So really important to taper down the dose. I'll let you read those adverse effects there. If you'll notice, the first portions of them have a lot to do with the central nervous system. So strange dreams, personality changes, that goes alongside with some of the reasons they would be taking it for behavioral health. Now, the other ones, again, all have to do with its effects on the peripheral vascular resistance and hypertension. And then because we are causing both agonistic and antagonistic effects, it's going to affect the male sex organs as well and the bladder. There are some drug-drug interactions to know with clonidine, really important. Phenylephrine itself, extremely important not to give it with an MAOI. Already talked to you about why. Same thing with tricyclic antidepressants. So it can be used in conjunction with tricyclic antidepressants, not necessarily a contraindication, but you need to use it with extreme caution. And as far as clonidine is concerned, if you take it with a tricyclic antidepressant, you actually reduce the therapeutic effect. So they're kind of working in opposition of each other. With the midodrine, you want to make sure that you don't give it with digoxin or beta blockers or antipsychotics. Now, digoxin is a medication for heart failure. We won't be talking about it. You'll be talking about that in Adult Health 1. Just know that with midodrine, you don't want to give it with those medications. Now, why would we give it with an adrenergic antagonist? Well, of course, we don't give it with an antagonist because it's an agonist. Why give it in opposite of each other? They're going to break even. It won't provide any net benefit. Okay, so we've come to the section again about nursing considerations. These are key nursing considerations that you need to be aware of when you're caring for a patient on any of these adrenergic agonists, particularly the ones that we just talked about with these alpha specifics. So it's not totally unlike our other adrenergic agonists that aren't specific. However, there's a couple points to remember. With your phenylephrine, you want to make sure you're evaluating your peripheral lines really importantly, because if it extravasates, you want to make sure that you know how to treat that with the pentylamine. Also, you want to be really careful and cautious about educating your patient to take those position changes very slowly when they're moving from one position to a next. Also, you want to make sure that you educate your patient about suddenly discontinuing these medications, particularly with clonidine. That can cause severe and sudden rebound hypertension. So you'll see on the next slide when we talk about patient education, it's a lot of what I'm talking about here. So everything that we talked about before with nursing considerations for those non-specific agonists, but in particular adding to those are these alpha specifics. You want to make sure talking about that phenylephrine with the IV site and the midodrine and the clonidine, those particular things that we talked about. Here we are with that patient education side. I already talked about most of this stuff about not sudden discontinuation. You need to make sure you educate that patient to taper down the dose. If you don't taper down the dose, you're going to have sudden and profound rebound hypertension. So it's really important to educate that patient. Don't just quit cold turkey. They have to make that change slow. Of course, making sure that you educate that patient to take position changes slowly. Make sure they know about any drug-drug interactions. Most patients don't consider herbal supplements to be a drug, and so they may not tell you if they're doing that. Also, finding out about their lifestyle. What do they drink? Do they drink any drinks that have typical energy drinks that might have any caffeine in them or something else that might interfere? Okay, so we're moving on now to beta-specific adrenergic agonists. So what we're looking at now is just those adrenergic agonists or some pathomimetics that are going to affect the betas. Now that could be one beta or both betas. We'll talk about that as we get to each individual medication. So on here you'll see albuterol. Remember we talked about albuterol during the sympathetic nervous system man with our beta 2 agonists. And terbutaline, which is also our beta 2 agonist. And isoproterenol. Again, we really aren't going to cover that one. It has so many cardiac toxicities, it's really not all that relevant anymore. It's really a last resort in the worst case scenario for a patient with severe cardiac disease. So how they're absorbed is varied. It really just depends on the particular medication. They're metabolized in the liver and they're excreted in the urine. Again, here is a little more information on isoproterenol. We're not going to talk about it. I'm not going to ask you about it on the exams. It's here because it could be something that pops up again as you're going through your studies for your NCLEX later on at the end of the program. Terbutaline, though, is relevant. Terbutaline is something that was used frequently in labor and delivery. It's also used as a last resort for patients who are having severe asthma attacks. In the labor and delivery realm, it's not used as frequently as other tocolytics that are more specific. So ridodrin, for example, ridodrin is a tocolytic that is specific to beta 2, which means it's not going to have any beta 1 crossovers. It's not going to do anything when it comes to a cardiac effect. It's really going to be specific for uterine relaxation. So terbutaline, you're going to see it. It may end up working in labor and delivery, or you may find it there, but mostly it's going to be something that's used as a last resort for patients who have severe asthma. It can be given both inhaled and IV. If it's given IV, it's typically, again, because of those bronchospasms or an asthma attack. It will relax the uterus, so if you have a pregnant patient that has asthma, know that it will have crossover to the patient's uterus. Side effects, typical because they involve that cardiac and the lungs, so you're going to have tachycardia and palpitations. tremors and nervousness. It's going to cause jitters. That's what it's going to look like for the patient. Sometimes the jitteriness will translate as anxiety. Shortness of breath and chest tightness and discomfort, sweating, high blood sugar, nausea, vomiting, and it's also going to cross over to the baby and cause fetal tachycardia and potentially fetal hypoglycemia. What don't we want to give it with? Well, we don't want to give it with a beta blocker because, again, that wouldn't make sense, right? Why give an agonist with an antagonist? Later on, when we get to respiratory, we'll talk more about albuterol. So in this section, we all just talked about terbutaline for the most part. Okay, so we're moving on. We are now discussing adrenergic antagonists. So still working in the sympathetic nervous system, but this time we're blocking it. Now, one of the most frustrating aspects of adrenergic antagonists for students is all of the AKAs. Getting to know what these are can help you going forward because you're going to see them used interchangeably. And if you hear a faculty member or an instructor or one of your clinical instructors or nurses or doctors you work with, if you hear any of them talk about these in different AKAs, you're going to know exactly what they're talking about. So get really familiar with this. Your adrenergic antagonists, also referred to as sympatholytics, also referred to as alpha blockers, beta blockers, or even alpha beta blockers. What their intended use is to block the sympathetic nervous system stimulation by any of those SNS transmitters or adrenergic drugs. They have the complete opposite effect of adrenergic drugs. Remember, adrenergic agonists are going to promote the same action of the sympathetic nervous system. And on the other side, the adrenergic antagonists are going to block it. So it's going to be promoting in the sympathetic agonist and blocking in the sympathetic antagonist. So here we have a couple examples of blockers that do both alpha and beta. This can be a little concerning because it's not specific. It's going to block both alpha and beta. It's going to be competitive, so that means it's going to work hard to occupy all of those receptor sites on both sides. What it will do by occupying alpha 1, beta 1, alpha 2, beta 2, and block is going to decrease the demand on the heart overall, lower the heart rate, lower the blood pressure, and it's also going to increase renal perfusion. So it's going to promote more blood flow to the kidneys. By doing that, the kidneys stop releasing renin. Remember that renin is responsible for increased blood pressure. So it's going to reduce the overall demand. A couple examples of these medications that can be used for just essential hypertension: labetalol. Amiodarone is a medication used as an antiarrhythmic, so it's going to try to bring that heart back or the rhythm back to a normal EKG. And then for heart failure and hypertension, carvedilol. And you can see labetalol and carvedilol are both lols, right? And then amiodarone is different. So you can't expect that they're all the same medication, right? They're not all the same class. However, they all three block both alpha and beta. Now, just your alpha blocker, right? The problem with just an alpha blocker is that they can cause problems with alpha 2, which is your overall CNS effect, right? So we really don't want to block alpha 2 if possible. We'd prefer not to do that. So these are not used as much. There are newer and better drugs that have been developed. So one of the more important things on here, though, is that an alpha blocker that is used is pentolamine. And pentolamine is used for any extravasation of a vasopressor, specifically neosynephrine. So if that vasopressor extravasates from the IV and it gets into the tissues, it can cause extreme tissue death, right? Because the tissues are just shrinking and it's causing the hypoxia of those tissues. Pentolamine, if you saturate the area, can help promote that dilation and get blood flow back to the tissues. Okay, so here we are just talking about alpha 1 specific blockers. If you take a look at your sympathetic nervous system, man, it will be helpful to note what it happens or what does sympathetic nervous system stimulation do in an alpha 1. If you see everything it does in that alpha 1 category and then you're going to block it, what does it do? Well, it's going to be the opposite of that, right? So instead of constricting those vessels and increasing the blood pressure, we're going to do just the opposite. We're going to cause vasodilation. We're going to promote a decreased or relaxed vascular tone. We're also going to relax the bladder, the prostate, and we're going to prevent ejaculation. Up on that sympathetic nervous system, man, take a look at that, and you're going to see also that it's going to alter the eyes. Instead of dilate, it's going to constrict, and then it's going to cause dry mouth. A couple of medications that we use for this are going to be Flomax, also known as Tamsulosin, and then on your chart you're going to see Prazosin, also called Minipress. Now for Prazosin, they do tend to use that more specifically for hypertension, but they're also going to use it for the prostate. More specifically for the prostate, it's going to be Tamsulosin, but because it does all alpha 1, it is also going to cause hypotension. Here's another slide about the BPH and exactly what it looks like, how it works when we're blocking alpha 1 receptors in that prostate and bladder. So it's going to prevent any resistance, allowing the patient to urinate, preventing that obstruction anymore. So in a lot of patients with BPH, they tend to urinate tiny bits at a time frequently, and they have that constant sensation that they have to urinate, lots of pressure. So Flomax is going to open all that up and allow them to go. Unfortunately, though, it's going to cause hypotension. So if you have a patient that already has low blood pressure, this is not the right medication for them. Some problems with just your alpha blockers, well, there's lots, right? Take a look at that alpha 2. So what does alpha 2 do? It's going to be CNS depression. It's going to lower hypertension, decrease peripheral vascular resistance, and it's going to promote sedation. Well, what happens if we block all of that? So if we're going to block all of that, we're going to create all kinds of havoc in the central nervous system. It's still going to look strange. The patient's still going to have weakness and fatigue, dizziness and drowsiness and depression. Now, some of the most challenging aspects of an alpha blocker, particularly for patients with BPH, is they will suffer from impotence or incontinence. And those are going to be two possibly deal breakers for those patient populations. And they may end up being non-compliant with their medication therapy. Even if they weren't taking it for their prostate, if they were given the mini press just for hypertension, they're going to have this potential, really high potential for side effects. So you might find a non-compliant patient population. Now, some drug-drug interactions, other nitrates and calcium channel blockers, ACE inhibitors, and then medications specifically for erectile dysfunction because they can cause more hypotension. You'll get into what these medications are a little bit deeper as we get into the program, but for now, just know that because they cause low blood pressure, if we couple those with one of these medications, it's going to cause even lower blood pressure. So that's why it's a drug-drug interaction. Okay, here, so we're talking about these beta non-selective adrenergic antagonists here. So take a look at your sympathetic nervous system, man. Everything you see in the beta 1 and beta 2 is now being blocked. So we're going to decrease the heart rate. We're going to decrease the cardiac contractility and consumption of O2. We're going to decrease arrhythmias, and we're going to block renin release in the kidneys, which will help to prevent any rebound hypertension. However, we're also going to cause bronchoconstriction. Instead of dilating those lungs, we're actually constricting them. So huge, right? We're also going to decrease intraocular pressure around the eye in open-angle glaucoma patients. Now, how do we accomplish this? We don't actually dilate the eye. We actually dilate the vessels around the eye, reducing that pressure. And here we are with our beta 1 specifics. So this is going to be far better, much more indicated for any patient that has any respiratory involvement. So if we're going to treat them for hypertension, if we're going to treat them for any kind of cardiac involvement, if they have any respiratory issues, COPD, emphysema, asthma, this is going to be better for that patient. A beta 1 specific, it will not involve beta 2. So in these beta 1 specific adrenergic antagonists, we're going to reduce that stimulation in the heart. It's going to help with heart rate and the contraction. It's going to decrease the conduction through the AV node. It's going to decrease that renin release from the kidney. So it's doing all of those great things that the heart might need. However, it's not going to affect the lungs. So this is by far more acceptable and more indicated for any patient that has respiratory involvement. So if you see a doctor who's going to prescribe something that's not specific, like propranolol on your sympathetic nervous system, man, remember propranolol was everywhere, right? So if you see your doctor is prescribing propranolol and you're supposed to give that, you want to make sure that you double check that your patient has no respiratory involvement. Another picture here of indications for beta blockers, why we might use them. All things we talked about in class, although we don't really discuss angina all that much. You're going to talk about that more when you get to adult health. This just means that we're going to help reduce that chest pain because we're decreasing the cardiac oxygen demand in the heart. So what are some problems with these beta blockers? Again, this includes beta 1 and beta 2. So these are both. So some problems with these, their central nervous system involvement, there is still some central nervous system involvement. Cardiovascular, mostly you're going to be concerned with the bradycardia because we're stopping the sympathetic increase, we're causing the heart rate to go down. If you do give a beta non-specific, you're going to have to worry about what it's doing to the patient's lungs. Is it causing any constriction? And then down there at the bottom, really important to understand, a lot of our diabetic patients are going to be taking these medications at the same time. It happens to be a really common comorbidity where the patient takes the patient both has hypertension and diabetes. So the problem with this is that as you get the patient into a non-selective beta blocker or even a beta selective blocker, the patient may not know what's causing their symptoms, their feelings, where they're jittery, they might feel like their blood sugar is low, and so they may be attributed just to their blood sugar, or they may contribute it just to their beta blocker and they don't check their blood sugar. So that's kind of a thing where you want to make sure you educate your patient. If you get to where you feel a little bit lousy, you're not sure what's going on, you're thinking maybe it's low blood pressure, check your sugar. If you're thinking it's low sugar, check your blood pressure. See how that works? Any drug-drug interactions with these, that's going to be clonidine because it's going to cause further central nervous system depression. NSAIDs, rifampin, and barbiturates. This is going to cause a decreased antihypertensive effect. So basically what's going to happen is they're counteracting each other. So you as the nurse, how do you need to talk to your patient about this? What do you need to do? Well, again, if it's an inpatient situation, it's really no different than your alpha and your patient education that we talked about before with your sympathetic nervous system. However, in this case, some of these are going to be more outpatient basis. So you want to make sure you find out, does your patient have any existing cardiac or pulmonary disease? You're going to want to make sure you check your patient's vital signs before you give these medications, because if the intent is to lower their blood pressure, you need to make sure that their blood pressure can handle that drop. Check the heart rate as well, because medications are going to affect these, such as the beta blockers, right? Want to make sure that you check their vital signs ahead of time. If it looks bad, you don't give the medication and then you contact your doctor, right? If you're going to educate your patient, you want to make sure you tell them kind of the same thing. You need to be checking your blood pressure and your heart rate at home. Otherwise, they don't know when to not take the medication. They just take it as prescribed and then they wonder why they feel bad. Or you have patients where they are non-compliant with the medications because they don't understand what to be expected. You want to always make sure you tell your patient that they need to change positions very slowly, very important, right? Because you don't want the patient to have a sudden drop in blood pressure or heart rate that can cause them to have a fall. Now down there at the bottom with the elderly, really important. The elderly are not heat tolerant in the first place. So you definitely got to make sure that your patient avoids any extreme heat, especially if they're elderly.